Since we have got a large participant gathering of about 300, I think we can start, no? Dr. Manoj?
Yes, we can start.
Yeah, I need to make me this host so then I can share my presentation.
Okay. So meanwhile, I'll just start on that. So good evening, everyone, and a very warm welcome to tonight's session of GP's Café. So today I'm really honored to be your moderator for this session, organized by the Spice Route Sri Lanka, affiliated to Wonka. So today our speaker is Dr. Kasun Randeep. He is an MBBS graduate from University of Peradeniya, who completed his medical degree in 2014 and is currently serving as a medical officer at the radiology unit of District General Hospital, Mathura. And he has been extensively involved in general practice for nearly a decade with extensive experience in primary care and non-communicable disease management. Dr. Randeep holds many other professional qualifications, out of which he has completed the certificate course in diabetes care conducted by the Sri Lanka College of Endocrinologists. And he also holds a fellowship in cosmetology and aesthetic medicine and has successfully completed the certificate course conducted by the College of Palliative Care Medicine. In addition, he is a member of the College of Palliative Care Medicine Sri Lanka, and currently he is a trainee of the MCGP program in the 11th batch under the College of General Practitioners Sri Lanka. Furthermore, for the past 5 years, he has been actively serving as a council member of the Ruhunu Clinical Society Mathura, contributing significantly to continuous medical education and professional development within his region. So today, Dr. Randeep will be speaking on a very important and highly relevant topic to general practice in everyday general practice, from guidelines to ground reality, NCD management in primary care. Over to you, Randeep.
Thank you very much, dear Dr. Caldera, for your kind words. So let me to begin with sharing my presentation. May I start?
You may start, Randeep.
So am I audible? I think. So am I clear to you all?
You're clear.
Yes,
You're
clear.
clear.
Yes.
Very
Okay.
clear.
So good afternoon, everyone. So first of all, I would like to thank all the officials of the GP Cafe and the CGPSL for giving me this opportunity. So today I'm going to talk about the non-communicable diseases, NCDs, the diseases like hypertension, the diabetes, and cardiovascular conditions, and also they are dominate in our day-to-day clinical landscape. So this effort is to bridging the evidences to the practice. So in the real world, there is a marked gap between the guideline recommendations and real world primary care implementation. So today we are giving a try to explore the practical strategies. So to translate these evidences into effective and patient-centered NCD management. So moving from the papers to the practice and then from the guideline to the ground reality. So this is my first slide. So do I need to wait in the queue? I just want to show a report. So these are the common patient perceptions in NCD care which we are encounter in day-to-day. So this slide captures the common patient perceptions that are create barriers to effective NCD care. So each of these points reflects a gap in understanding the between well-being and feeling well and being well. So in a context of chronic disease. So patient might think that if he is not having symptoms, so his disease may be under control. So the test results will be normal and he might think that the disease is not causing any harm at the moment. So the other thing is, as he is taking medicine, he may think that there is nothing much to be done. So the etc. So the other thing is, mostly our people think that Western medicines
කියන්නකො මම
are
එහෙනම් දාන්න.
Western medicines are coming with many side effects rather than the Ayurvedic and the traditionals are mostly safer. So our role is to help the patient to understand this. So our final line is the most important thing. The NCDs mostly do not speak until the complications do. So we are helping our patients to understand the silence and act before these complications speak for them. So the ground reality is many times patients are interpreting their reports by their own. So the long-term drugs without reviewing, they are continuing them and repeating them over and over again. So the poor adherence is there. High complication burden will be the ultimate consequence. So the patients are making decisions based on their incomplete understanding. So the medications prescribed, but they are not taken consistently. So the end result is a tragedy. So for the completion's sake, the non-communicable diseases are having two key features. They are non-infectious and they are long-lasting. So while many conditions are falling into this category, the cardiovascular diseases, cancers, and the chronic respiratory diseases, and along with diabetes, are responsible for the vast majority of these global deaths. So critical takeaway is the final point. The NCDs are the world's leading cause of death. So a few words regarding the WHO assessment of the NCD burden. So it is nearly 83% of all deaths in Sri Lanka. It is a massive majority. They remain a major driver for the premature mortality. So according to the hospital data, nearly half of all in-hospital deaths are due to these NCDs. So these are not just health statistics. It is a national priority affecting our families and the healthcare system and the workforce. So this is the ground reality. So we should try to change it. So with that, I would move into the risk factors for the NCDs, the framework for understanding why NCDs are so prevalent. So we can think of risk factors as a cascade or as a chain of events. So it starts with the non-modifiable factors, which we cannot change like genetics and age. So these influence and amplified by the behavioral factors. So the daily choices are like tobacco, diet, activity, alcohol, and all. So these are our primary target in prevention of the secondary prevention. So these behaviors in turn lead to the metabolic risk factors. They are the measurable conditions like blood pressure and high blood pressure, blood sugar, and the high lipid levels. So these are the direct pathways to organ damage. So the final outcome is development of major NCDs, cardiovascular diseases, diabetes, and so on. So then we move on to the primary care role for the NCD prevention. So we do have, as the primary care medical officers or the general practitioners, we do have multi-layered role in primary care in the NCD battle. So we are not just prescribers. So we are the front line. So prevention and the lifelong management of these conditions. So our work spans in several levels. So that primary prevention, so we counsel and empower the patients and we advise them to avoid risk factors. So next is the secondary prevention. So we detect early signs and like high blood sugar or high blood pressure. So we intervene before the complication occurs. Then comes the tertiary management. So for the people who have established diseases, we provide the continuous care to control and prevent disability. So the most important role is we provide continuity. We are the consistent guide throughout the patient's life. So now we are moving into our case scenario. This is regarding high-risk patient who is a private sector executive. It is an example of multimorbid metabolic syndrome. So these are not rare conditions. We are frequently seeing these type of patients. So this patient is 55-year-old high pressure executive with multimorbidity, a cluster of diseases like diabetes, hypertension, heart disease, and dyslipidemia, all four are there. So the lifestyle is a textbook of modifiable risk factors like sedentary lifestyle, stress, poor diet, and poor sleep, and also the erratic meal pattern and notes. So crucially, he is now having early signs of decompensation as he presented with edema and worsening of breathlessness. So his heart may be starting to fail. So his strong family history on top of that, given strong and significant non-modifiable risk. So this is our cold reaction. His case moves beyond simple prescription. So it requires comprehensive strategy to address all root causes and prevent rapid progression to major complications like a heart failure or major heart attack or cardiac event. So with that, I gave a clinical summary of the chronicity of these diseases. So he is not a new patient. So these diseases are there for about more than a decade, and his hypertension is there for about 15 years, and the diabetes is there for about 12 years. Dyslipidemia and ACVD all are same. So we have to suspect that this patient may be having metabolic dysfunction associated steatotic liver disease. That means previously the nomenclature was the NAFL, that means the non-alcoholic fatty liver disease. Now they have moving from the negative diagnosis into a positive diagnosis. That means metabolic dysfunction will lead into the steatotic fatty liver disease. So this slide shows why we are now seeing symptoms, the ground reality of poor control over years and years, leading to his body to the tipping point where complication begins to speak. So major management challenges are, here is the primary management barriers. Those are the executive trap and the medication inertia with complex interconnected multimorbidity. So that being a perfect example for a for an executive trap means high pressure lifestyle that directly conflict with the routine needed for good health. So this has led to a medication inertia. That means he has taken medication over years and years, but the treatment goals are not achieved. So he is a very high risk patient for with established ACVD, it means atherosclerotic cardiovascular disease. He had a MI 5 years back. So there are features of target organ damage, And also there is dangerous atherogenic lipid trial, that is high LDL with high triglyceride and also low HDL. So on top of that, he is having powerful genetic predisposition as his father had a myocardial infection, myocardial the infarction at early age. So our strategic focus is to approach and simplify treating numbers. That means changing from simply treating numbers to a risk-based management. So aggressive secondary prevention is a must. So we have to make a sustainable lifestyle changes. So we must help him to integrate his health into his busy life. So it is not the other way around. So our goal is to move him from high risk trajectory to a stable control chronic state. So our focus clinical assessment is, in the history, he looks like an asymptomatic, but he's not asymptomatic. He's having ankle edema and breathlessness, meaning his heart is going to fail and it may be a type C heart failure. So the physical findings are also having high BMI of 34.8 and also with mild ankle edema and with a high waist circumference. So other investigation results also reveals the data related to the multi-organ involvement and the signs of multi-organ damage is there. The kidney wise reduced EGFR noted with early microalbuminuria and also the ECG revealing LVH. So the liver shows the elevated enzymes with the imaging showing the features of fatty liver. So the severely uncontrolled diabetes with HbA1c of 8.9. So despite of all the treatments, the HbA1c is 8.9. So this is not uncommon. We are encountering these type of patients day to day. So having a huge lot of pills and medications, get a HbA1c of 8.9 is utter failure. So this established multi-system disease with the evidence of end-organ damage, every finding holds an urgent, aggressive management to prevent his rapid decline to a sudden cardiac death or a major cardiovascular event. So I would like to discuss much more about the attitudes toward this patient after having a chat with him regarding his illness. The attitude is very much interesting. So he thinks that being a successful businessman in the office room maybe help him to save his health, but it is not the reality. And also he thinks that doctor, if you can give me the strongest or the better feel so that I can stay without thinking about my illnesses. So that is not the reality. So the other thing is he had a myocardial infarction about 5 years back. So the stenting make him to come back to the work again. So he thinks that whatever happens in the future also something will save him and get him back to the work. So it will not be the reality. So these are the patient's attitudes. So it is not a simple thing. It is a huge barrier to the proper management of these NCDs. So moving forward to the cardiovascular risk stratification. So we have identified the comprehensive problem list here. Being a patient with having established ACVD and uncontrolled type 2 diabetes and hypertension, dyslipidemia also there, and also the obesity and general both central obesity was there. So we have to go for the risk stratification according to the global guidelines. So there are guidelines as given in globally. There are risk scores, European Society of Cardiology, and also the American Diabetes Association, and also along with the WHO Global NCD framework. There are subtle differences in the scores. So we have to somehow or the other go for the secondary prevention with this to achieve our absolute goal to prevent this patient failing in near future. So, some few words regarding these scores. So, the ACVD is by the US for the USA population, and score 2 is for the European population. So, the Q risk 3 is the most precise score and bit of a complex data entry. So, it will give a very precise score regarding the risk. But being in the Sri Lankan population, Society for Hypertension, Southeast Asian region, score will be give a good score for a Sri Lankan population. As the Ministry of Health is recommending WHO Tier 3 charts for the community-based risk assessment. So this is more about the complexity of these charts and using for the Sri Lankan population. So as a general practitioners, we can use this chart. It is very much simple in our simple to use in our general practice. So ACVD and score 2 can be used in our day-to-day general practice also. But the curious will be little time consuming. So still, we can use WHO CL charts to stratify our patients' 10-year cardiovascular risk. So this is something about the WHO ISM charts. So there, it is very simple and self-explanatory. So there is 2 charts for the each gender and smoking status and the diabetes status. So you just have to put the patient's age on the vertical axis, and you will get the horizontal axis with the systolic blood pressure, and you can get the risk level. So the color code is there. The green is less than 10%, and the yellow is 10 to 20%, and the orange 10, 20 to 30, and red is more than 30. The high risk, very high risk category. So then there will be the recommendation and the treatment goals according to the risk category. So I must say some words regarding the Sri Lankan cardiovascular disease risk score. It is SLCVD risk score, so it is tailor-made for the Sri Lankan population. So it was developed by the Kerala University and the Sri Lanka College of Cardiologists. So they have identified the premature coronary artery disease risk, which is there for the Sri Lankan population. So usually 10 to 15 years earlier, they are getting heart attack than the Caucasians. So there is another concept that we are having high risk fat and insulin resistant, though we have normal or near normal BMI. That is why CVD score, they have addressed these and they have fixed those issues. So with SLCVD, they are using metrics like total cholesterol and HDL ratio and South Asian BMI cutoff. So they will give a correctly identified dangers earlier than the European or the other risk scores. So it will be better to use our population with these SLCVD risk score. So here you got the evidence-based treatment targets. His HbA1c target is less than 7, and fasting blood glucose is 80 to 130 with the postprandial glucose of less than 180. So blood pressure target is 130 by 80, LDL less than 55, and 50% reduction from the baseline. So the triglyceride less than 150 and body weight ideal reduction is 10% within a duration of 12 months. So the other concept is we have to look for the weight circumference. So the central obesity is a key factor for the insulin resistance. So just reducing his weight won't help much if he's not reducing his weight circumference. So here you have the medication list of the patient. So he is on 3 antihypertensives. It is ramipril 10 milligrams octane with amlodipine 5 mg BD and also HCT 25 morning. So the diabetes control is going with the highest dose of glycoside. It is 160 milligram BD with the metformin XR 1000 milligram BD. So the lipid therapy is maintained by the atovastatin 20 milligram noctate. So we have identified some problems with these combinations. Though he is on triple therapy, which is the correct regimen, still the blood pressure is 150 by 158 by 96. So it may be resistant hypertension. The glycoside higher doses will cause many more problems. The weight gain and also the hypoglycemia risk with the patient having erratic meal pattern. So the metformin glycoside regimen is too old strategy. So we have to go for the newer strategies like SLGT2 inhibitors or the GLP-1 RA agonist. So regarding the atovastatin 20 milligram is not enough to hit his target of 55 milligrams of LDL. So here you have the integrated drug algorithm. So first step is to mandatory secondary prevention, and then the diabetes management along with the hypertension control. So we have to then go for the dyslipidemia intensification, and also we have to consider the management of fatty liver disease. The final is the most important thing is weight and lifestyle strategies. So we will move one by one. So step one is mandatory secondary prevention for all patients. So when we see the medication list, you may wonder that where is the aspirin and clopidogrel. So the patient has intentionally dropped aspirin as he's getting gastritis. Gastritis is a biliary reflux disease. So that is how things are going. He had a stenting and he was nearly saved by stenting, but now he is just uh, withholding aspirin. So there is no negotiation. We have to start resumption of the antiplatelet therapy. So a few words regarding the antiplatelet therapy. So we have to consider whether we are going for a single or dual antiplatelet therapy, or else we can go for the dual pathway inhibition. So in the single antiplatelet therapy, so as a patient had the myocardial infarction about 5 years back, so we can straight away avoid to going for a dual antiplatelet therapy. So we can go along with the aspirin. So the other decision we have to take is the aspirin and the rivaroxaban combination. I mean, it means the preferred escalation, what I guess is the COMPASS regimen. The COMPASS regimen stands for the patients with chronic coronary syndrome who is having a high ischemic risk. It means his age has to be more than 65, or else he may have two or more risk factors from diabetes or kidney dysfunction or heart failure or smoking. So this patient is a good candidate to go with the dual pathway therapy. It is superior protection. It will be giving superior protection to this patient. So now we are moving to the diabetic management. So here metformin comes as the first line. So we have hit the maximum daily dose. If tolerated, we can go along with that. But regarding the glycoside, so we have to go for an alternative. So being a patient with high BMI, so glycoside won't be the good option. The other thing what I want to say is the popular or the conventional metformin and glycoside regimens won't give any prevent or any good or the benefit for his cardiovascular prevention. So then we have to go for the evidence-based add-ons like SGLT2 inhibitors like EMPA or the dapagliflozin. So they will protect his heart and kidney. And also when it comes to the GLP receptor agonists, it will give a powerful glucose control along with the weight loss and also more cardiovascular benefits. So as usually what happens, most of the patients are not willing to go for the insulin. So due to this needle phobia, we have to consider a bit of a low dose of glycoside MR formulation, especially morning dose will be enough if we can't anyway achieve the glycemic targets. So we have to consider, again emphasize the specific, role of the GLP-1 RA agonist for these type of patients. So the key patient factors are he is not willing to for the insulin, and he can afford for the continuous glucose monitoring. So it is not very much new thing, but it was there for a while. So we can gain a lot of from this concept of continuous glucose monitoring. So I would like to speak few words regarding the GLP-1 receptor agonist. So it costs the GLP-1 RA is a very good gold standard drug. So it will give a good weight loss with a cardiovascular protection, and also it improves the renal health. So it is not just, it all are evidence-based facts. So patient can invest on that. He won't have to regret anyway, as it will give very good outcome. So regarding some concerns of the GLP-1 RA, as most people are raising concern earlier regarding the cancer risk for the medullary thyroid and also the pancreatic cancers. So the recent evidences are saying that the benefits are very much more than the being the absolute risk is very low. So we can straight away go for that. So there are many forms of GLP-1 RA. So in this context, this patient will be benefited more from the semaglutide. So I just mentioned only that. So the oral semaglutides are available. That is the only form where the oral form is available. So we can go for the 3 milligram to 7 milligram daily dose. But when it comes to the subcutaneous semaglutide, it will give a better adherence. Being a patient with this much of a busy schedules, it is giving a superior outcome for the major adverse cardiovascular events to reduce. So few words regarding the continuous glucose monitoring. So it is available in Sri Lanka, so we can get it. So the average cost for per 2 weeks is around 15 to 18,000. So it is not that costly. So we can gain a lot from this CGM, the continuous glucose monitoring. So you may wonder why I am talking about the CGM, being the patient is not willing to take the insulin. But in a patient without insulin, we can achieve a lot from the CG. So there, the metrics it gives other times in range TIR. It means how much time he stay in between 70 to 180 milligrams of deciliter blood sugar level. So our clinical target is more than 70% of the time we have to stay in the 70 to 180 window. So the other thing is we can get a clear idea about the glycemic variability. So our target is to go less than 36% of variability. So the low variability prevents the vascular inflammation. So the other thing is we can get a clear idea about the hypoglycemic risk. So we can measure the time below range. It means how much he is going below 70 milligrams per deciliter of blood sugar level. So it is very important. If we are going along with the insulin or the glycoside, so if we are going with the higher doses of nucleoside, so it will be very much beneficial. So the other thing is we don't have to wait for about 3 months to repeat the HbA1c. Then and there after 2 weeks, we can get an idea about how will be his HbA1c if he is going in this style. So there are few more benefits. If even as doctors we can estimate how our sugars are behaving with our daily day-to-day routine. So being a general practitioner, you can check whether what is happening during your consultation hours. Also, patient can get an idea how his meal pattern affect his glycemic behaviors. So it is very much important. So it costs roughly around 15 to 18,000. So something regarding the medical nutrition therapy. So this slide is beyond generic. I mean, giving eat healthy advices. So it is far beyond that. So precision nutrition strategy is tailor-made for the metabolic diseases. So counting calories, avoiding sugars is the conventional method. So now we have to have some newer strategies, so we have to use them. So there are few strategies. I think it is a separate topic, but I will speak few words about that. So the precision plate protocol is the timing of the eating. I mean, we first have to eat fibers and fluids. Then we can go for the protein and fat. Then the last, we have to go for the carbohydrate that has to be low glycemic index. So the sequence can blunt the glucose spikes. So it is drastical reduction. It can be reduced by 30 to 50%. So it is a huge benefit. So these simple concepts will give a very big benefit for the final outcome. So there are many other uh, concepts that one is the glycemic dynamic studies and the food engineering. It means the mixed meal effect. That means using our own meals to make a low glycemic index meal pattern. So there are other concepts like reheating and cooling, making resistant starch formation. So those are a bit of a complex things, and it is beyond our uh, goal for today. So I will moving on. So our step 3 is the hypertension control. So already this patient is on 3 antihypertensives. But he's not achieving his target. So we can optimize that. We can go for a near maximum dose of the AC inhibitors or ramipril or the enalapril. So then we can consider into a long-acting ARB. So other thing is we can switching from HCT to the HCT to a better thiazide like indapamide, which will be having 24-hour control. So the other thing is, anyway, if we can't meet the hypertensive targets, so the game changer is adding fourth line. It is the spironolactone. We can go with around 12.5 to 25 milligram of dose. So for the hypertensive control, so we have to use these type of strategies for this patient. So regarding this, the patient is having the ankle edema, so it can be multifocal. It may be induced by the amlodipine. So it may be induced by the early heart failure. So it may be related to the diabetic kidney disease. Anyway, so we can give a try by shifting to the cilnidipine from the amlodipine. So it will be having a bit of low effect on peripheral edema. And also it is dual L and N type calcium channel blocker, so it may cause less peripheral edema. So the other thing is we can with the combination of ACE or ARB along with the SLGT2 inhibitors, it means the ramipil, enamipil, or the losartan or the telmisartan, with the introduction of the empagliflozin or the dapagliflozin, it will help to lower the BP along with reduction of the food fluid retention. That will automatically help to resolve the bleeding. So as I previously discussed, the spironolactone is the fourth line. So we can go for that if we can't achieve the targets. So some few points regarding management of the resistant hypertension. So there, according to the international guidelines, we have to go for less than 130/80 target for this patient. So I want to emphasize, give an emphasis regarding the rule of 10. So every 10 millimeters of mercury reduction of in systolic blood pressure will be give a 20% reduction of major adverse myocardial events. So it is a huge reduction. So to achieve that, we have to have precise monitoring tools. So we can go for the office blood pressure monitoring. It is conventional and it may be associated with the white coat ticket. But if you can have home blood pressure monitoring, so it will give a better benefit. So the gold standard is the ambulatory blood pressure monitoring. So it will give a very important information regarding the patients who are non-dippers. That means there are a set of people, their blood pressure won't drop at the night. So it is high risk for to develop them to develop diabetes. So then we move on to the dyslipidemia management. So here we have to have non-negotiable target. That is, we have to go below the 25 milligrams per deciliters of LDL level, or else we have to reduce the level of LDL by the 50% from the basal level. So for that, we have to go for the high intensity statins. So rather, we have to go for the atorvastatin 80 milligram or rosuvastatin 40 milligram. So the other thing we can offer is, as most of the patients are complaining of myalgia and other intolerance to the high intensity statins, the treatment failures will be very much higher. So we can combine them with the ezetimibe. So it will give a maximum reduction of the LDL level. So it will be beneficial for this patient if the cost and all the financial level will permit for that. So the other step 3 is PCSK9 inhibitors that will be reserved for the specialist level management. So if we compare the atorvastatin high dose alone therapy with the combined therapy with the ezetimibe, so it is having a superior potency. So these all are proven facts. So these type of patients can be effectively managed with, according to my knowledge, with atorvastatin 20 milligram with a better tolerance and adding ezetimibe 10 milligram daily dose. So next we have to have few words regarding the fatty liver disease. So the stratification will be done with the fifth score. It is very simple score. So you have to have age and the HbA1c with full blood count. So there is an equation to form the fifth score. So they are less than 1.3 will be low risk for the fibrosis, and 1.3 to 2.6 is intermediate, and more than 2.6 is high risk for the advanced fibrosis or the developing CLCD. So when we summarize the imaging cascade of the fatty liver disease, regarding the ultrasound, it comes as the first step. So grade 1, 2, 3 fatty liver, it is very famous. So the major limitation is the fatty liver assessment of the ultrasound is very much machine and the user dependent. So to overcome that, we can go for the FibroScan along with risk stratification from the FIB score. So the if the first we have to stratify the risk of this patient with the FIB score, and then we can go for the FibroScan if he is falling into the high risk categories. So there they will give measures regarding steatosis from S0 to S3. And after that, it measures the stiffness of the fibrosis from F0 to F4. So that is about the fatty liver disease. So I want to highlight regarding diverse pharmacotherapy for the people who are having established fatty liver and fibrosis. So there is a marvelous drug, which is the only drug is having FDA approved. So it is resmetirom. So average cost per day is around 1,000. So I have seen some patients or even colleagues have taken, and it is having marvelous results. So I wanted to mention that also here regarding fatty liver disease management. So then comes the step 5. It is weight and lifestyle strategy. So here previously also I have discussed a little regarding this diet and the precision multi-nutrition therapy. It is a newer strategy. So there are a few concepts. So as it is a separate topic, so I will be not going to more details regarding that. So regarding the activity, I mean prescribing exercises and all, we have to have a good plan for this patient. So precision of lifestyle strategy, it means so the biographer protocol, that means the previously mentioned fiber, protein, carbohydrate sequence of feeding. So the other thing is with the sequence, it can trigger the endogenous GLP-1 release. So it will be beneficial to reduce their weight. So with the precision lifestyle strategies, we can achieve, along with the pharmacotherapy, we can achieve better targets for this patient. So I want to mention something regarding this, the exercise prescribing. So here, the newer concept is not newer, rather it was there for a while. So the HIIT is superior, giving superior outcomes than the moderate intensity chronic training. So there, if you can do some, high intensity exercises for about 15 to 20 minutes, 3 times per week, like so, it will be superior, giving superior benefit rather than having more than 150 minutes of walking along hours and hours. So the other concept is we can advise them to have activity snacking. That means each and every hour you can have a break for 2 minutes and do some exercise. So it will prevent the sedentary shutdown. So with that, the prolonged sitting and all, so it will cause harmful vascular stiffening and metabolic shutdown. So this dual strategy fit can be fitted to his schedule very well. So the short intensity workouts for maximum benefit and frequent tiny movement snacks will neutralize the damage of his sedentary job style. So regarding the sleep, so he's had a sleep of around 5 hours. It also a fragmented sleep, so it is not enough. So we have to motivate him to have more than 7 hours of sleep. So the other thing is stress management. So we have to advise him on strategies, better practical strategies to manage his stress. So the other concept, newer concept I want to mention here is vagal tone and plaque stability. Here you can have a technique called vagal nerve stimulation techniques by 5 minutes of box breathing. That means you inhale for about 4 seconds and then hold it for 4 seconds and exhale for 6 seconds and doing it for about 5 minutes. So that can calm your nerve system. We also can practice that. So it will reduce the inflammation to ultimately promoting the plaque stability. So this isn't, this is not wellness, and it is something advanced than that. So it is neurometabolic optimization it is critical for the success of the entire medical plan. So now we have come to the medication list. So the here I have planned him to go with the Ramipril. It was there for previously. It was 10 milligram nocte, and I moved into the sildenafil 2 milligram, 2.5 milligram RD, and along with that, long-acting indapamide 1.5 milligram SR formation. So the spironolactone was added for the hypertension control, and then the SLGT2 inhibitors with a 10 milligram MANI dose. So as he is having good commercial stability, so he can go for the semaglutide as he is having, needle phobia. So he chosen the oral form. So it is 7 milligram once daily dose. So the lipid therapy was planning to achieve via the rosuvastatin 40 milligram. The combination therapy is not started as there is a huge pill burden along with 10 to 12 drugs. So I decided to go with rosuvastatin 40 milligram dose. So the aspirin was there as it is 75 milligram daily. So now we are quickly moving on to the reviewing plan of this patient. So the summary of the 1 month review. So it is the metabolic rebound of this patient. So the blood pressure has reduced from 128 to 78. So then his blood sugars has come down from 180 plus to the 110. So the weight reduction was achieved 3.5 kilograms with the usage of GLP-1 and the SLGT2 inhibitors. So the liver ultrasound scan was repeated, but the staging is as it is. It won't change with a 1 month duration. So the echocardiogram is not done. So during first month. So when we next move into the 3 month review, so there he have achieved the HbA1c of 7.2. So the so-called LDL target also achieved 52 milligrams per deciliter along with the rosuvastatin 40 milligrams. So the urine ACR has come down from 45 to 24. It is 50% reduction of albuminuria. So we can see the renoprotective effect of our drug regime. So the FIB4 score has reduced from 1.6 to 1.3. So the fibrous can also show some improvement. Then the 6 month review, it is the total remission level. That is the ultimate level of targets that we have achieved. So successfully he has hit the remission level of HbA1c 6.4. So the weight reduction is ideal. It was the 10% weight loss that all patient has to dream with. So they can go for the remission. So we can go for a cut down of the treatment. So the fatty liver reversal is very much slow. It has reduced up to grade 2. So the not little, but a considerable improvement of the injection fraction was also noted. So a few words regarding reducing the pill burden. So it is inevitable in these sort of situations as the patient is having 4 or 5 morbidity, 5 NCDs. So we can't avoid that having around 10 fields per day. So, but we can, if the cost and the financial status permits, we can go for the single field combinations for this patient. So there are triple combinations available like perindopril and indapamide along with amlodipine, and also there are dual combinations like perindopril and indapamide, and also there are famous combination with metformin and empagliflozin, and metformin and dapagliflozin, and also there are combinations with statins and ezetimibe combinations also. So if we can consider the reduction of pill burden also, it will be good for the sustainable follow-up plan. So with all these, I want to discuss a little about the common pitfalls and mistakes in the real world practice. So I am moving to the end of my presentation. So the most of the time, there is a false reassurance from the normal 2D echo. Patients are thinking that if the echo is normal, so our cardiovascular health is okay. So the other thing is, mostly we as clinicians targeting to treat numbers, but we have to go for the as a whole, we have to treat and stratify the whole risk of the patient. So mostly we can see the suboptimal lipid management is happening. So that is always due to the due to not applying proper risk stratification strategies. So the other thing is, so delay in using of cardiovascular protective drugs. So it is mainstay of our management. So we do not delay to start our patients on SGLT2 inhibitors or rather GLP-1 RAs. So achieving targets is very much important. So we have to go for these newer drugs. So the treatment and the therapeutic inertia is another thing. So patients are having continuously taking treatments, but they think that they don't get a cure. So it is also a challenge for the treatment failure. So along with that, I will be moving into my last few slides. So the final slide grounds our entire case study in global evidence base. So there are not these are not our personal opinions. So these are the consensus recommendations from the world leading medical bodies. So the European Society of Cardiology, the American Diabetes Association, and the WHO. So the unified message for all guidelines is treat risk, not just the numbers. So the other thing is secondary prevention is not negotiable. So after heart attack, the goal is to prevent he is getting next one. So the lifestyle is foundational. So medication alone, we can't do anything. So it is insufficient. Diet and activities are also equally important. So the key continuity is the key. So the long-term and trusting relationship in our primary care as the primary care physicians. So it will be enables this complex and lifelong management. So this case demonstrate how to translate these global guidelines into a ground reality in our day-to-day practice. So thank you.
Thank you, Randeep, for that very insightful, informative lecture. I think since we're running out of time, shall we just concentrate on a few questions on the chat box? One question goes as, what is the best management of impaired diabetes mellitus? Is it diet only?
No, as far as my knowledge, impaired diabetic mellitus, so we can go with the diet, and also we can go with the lifestyle modification. It is the mainstay of the management. So if the patient is not achieving the targets, the best recommendation is to go for the early treatment. So it will be giving future benefits.
And also, they are asking where is continuous glucose monitoring available?
Available, so we can there are the representatives are there, so we can't tell the names. It is not ethical to tell the names, so it is there always. We can give the contacts and all, so it is available. It is around it was previously, it came for the price of 18,000. So with the new revision of the taxes and all, they say that it will be around 16 to 15,000. It is for the 2 weeks time duration. So especially it will be using for the ICU patients who are in the ICU setups. So to get a good idea about their glycemic control, and also being doctors and also being people with busy schedules. So we also can have our idea about our glycemic status with that.
And another question is there in the chat box. Among the many dietary approaches, which one do you find most practical and effective for managing NCDs in real world practice? Do you favor any particular dietary pattern, such as the Mediterranean diet, for managing NCDs?
So it is bit of a, we have to give a comprehensive answer. So in this context, what I think is that rather than giving to a special schedules or the patterns, as we are targeting a sustainable goal, so we have to we have to target our day-to-day meal pattern. So we have to adjust the day-to-day meal pattern. So rather we are sticking to a specific pattern. So we can do it for about 2-3 weeks, or rather month or 1 or 2 months. So it will not give any benefit for the long run. So what I suggest is, so optimize day-to-day our meal pattern and meal habits, where previously I discussed some concepts. So easily we can apply those concepts into these contexts. So rather than going for the popular patterns and all, best thing is to stick to the basics and go think about the long run.
And there's another question, Randeep. Treating diabetes for 15 years, if HbA1c is 6.4, can you stop metformin and be without medication?
So no, I don't think so. We can downgrade the medication, so we can reduce the doses for. But we, as per my knowledge, what I think is we have to maintain our targets. So after hitting the target, if we down escalate, so we will our targets. We will be failed. So we have to maintain our target. So what I feel is we can omit 1 or 2 drugs, and we have to go with the basic drugs like rather metformin like.
Okay, if there are any more questions, the forum is open for a few. So in the absence of any other questions, I would like to give a few announcements before we wind up. And Spice Route Sri Lanka is the Sri Lankan Young Doctors Movement under the South Asian Young Doctors Movement of WONCA. So GP Cafe is one of the initiatives of that. So we kindly invite all of you to join the GP's Cafe through the WhatsApp group, and we have shared the links in the chat box. So please go through that and make sure that you join our WhatsApp group to expand your knowledge and also to share similar experiences with us. And also, another announcement as to the CPD certificates. Like at the beginning, like we have got your registrations with the names and emails. So we will forward this to the ETR branch of the Ministry of Health, in which case after the notifications are given, the corresponding CPD certificates will be shared to the respective email addresses that you have registered. So we have come to the end of the session, and thank you so much, Randeep, for that insightful talk. And I would like to make a note of all our pioneers in the GP Cafe, including Dr. Asita, who couldn't actually join our session, I guess, because like we were loaded, we came to a maximum participant level of 300. So I would like to take a chance to thank our pioneers, Dr. Gobit and Dr. Manoj Lianage, and Dr. Priyanti, who is not here due to some reasons, because right now she's in Jaffna with the appointment. So, like, we would like to thank our pioneers and hoping to join again with another insightful talk again through GP's Cafe again. Thank you. Thank you all for joining today. Good night.
Thank you, everybody.